Hi, this is Bob Miglani.
And this is Dr. Shefali Miglani.
Welcome to the Specialist Doctor Marketing Podcast. In today's episode, you'll be hearing from Dr. David Kading, who talks about the words that convert. Words are very powerful in marketing, and Dr. Kading has become an expert on utilizing words, keywords. There's like 7 keywords that he uses to help convert patients into specialty care treatment. And these words are really powerful. And I think if we think about them and actually use them day-to-day practice, we're going to see a lot more revenue growth. So without further ado, here's Dr. David Kading, who is a specialist who has several clinics in the state of Washington and is an expert in specialty care in the United States, particularly in optometry. So again, here it is, Dr. David Kading. Thank you. Hello, everyone. Thank you. Let's get started. To be respectful of everyone's time, my name is Bob Miglani. I'm the host today, and I'm really thrilled that Dr. David Kading could join us today. Hi, Dr. Kading. How are you?
I'm doing great. It's great to be here, Bob. Honored to get to chat with you, as always.
Wonderful. Thank you so much. And what I would love to do is to share with the audience here, optometrists and colleagues that are eye care professionals, Dr. Kading's expertise in dry eyes and specialty care, not just dry eyes. As we all know, he's a very a prominent speaker. So we're going to give a little intro about Dr. Kading, talk a little bit about who we are, what we do. We're going to talk about best practices in the exam room and the key words that you might want to use in your exam room, in the COP visit or the ocular surface evaluation. Then we have a Q&A that's going to be moderated by me and some closing remarks. So let's talk about Dr. Kading, who he is. He's a top 50 influencer of all time. He's an author and a podcast host. And I've been on his podcast. He's asked such great questions. I love that he asks really insightful and really penetrating questions. And it makes you think a little bit, puts you on your feet a little bit. I really enjoy that. He walks the walk of specialized eye care. He's done it. He has a great a way about him when he presents at conferences, and he serves as the education chair for optometry education with the Optometric Physicians of Washington. He's a fellow of the American Academy of Optometry, and is quite active in committees and the formation of anterior sex special interest group, and is the only fellow in Washington State to have earned such status as the Contact Lens Society of America. So it's fantastic, Dr. Kading. Thank you for joining us. I appreciate it. A little bit about who we are. Hoot is a marketing automation platform. And we know that how doctors lose potential revenue because patients don't sign up for dry eyes or myopia management? Well, Hoot helps you capture and convert those specialty treatment patients with patient education and a clear process. Okay, that's kind of what we do. So let's get started. So I'm going to pause on this screen here for a second, and we're going to talk now dry eyes. So, Dr. Kading, why is dry eyes so important, first and foremost, for optometry in America today?
Yeah. Well, my grandfather practiced optometry for 50 years, and I don't know if he had a single dry eye patient. And reality is it just was not something we really thought of and really dealt with all that much. I'm sure there was a patient here or there that dealt with it. But it is part of every component of eye care practice today. My wife does pediatrics and binocular vision. She has dry eye patients. Some of my colleagues do low vision. They have dry eye patients. Whether you work in a VA hospital, if you're treating glaucoma, you've got dry eye patients. Every aspect of eye care that we have today deals with dry eye management and dry eye treatment. You cannot ignore dry eye in the optometry practices today. So why is it important? It's because it's everywhere, It seems as if over 50% of the patients that are in my chair are symptomatic for dry eye in some way, shape, or form, whether early or end stage. And all you have to do is ask your patients, do you ever think about your eyes from a dryness perspective, irritation, discomfort? I bet you in your chair, too, it's over 50% of the patients.
Yeah. And then, how has that been exacerbated, I suppose, over the last few years with COVID and these devices? Is that something that you're seeing?
Yeah, I think it really started about 2007, thanks to Steve Jobs, and it's just continuing to get worse. So absolutely, all of the things that are out there, particularly with digital device. My mentor, Dr. Don Korb, he believes that 90% of MGD is caused because of an impartial blink, and that's really because of our lack of quality blinking. And so, absolutely, digital devices play a big part into that.
Yeah. And also, I suppose that one of the most important things that we think about as a business is that it is a profit center. Increasingly, it's a place in terms of private pay where we can pivot our practices from primary optometry, right, to specialty care. So tell us speak a little bit about the business part of it, in terms of revenue growth and profit center. How's dry eyes been a contributor of that pivot towards the increasing the business growth?
Yeah. Well, Bob, one of the things that I've discovered is that the greatest unmet needs tend to have the greatest business opportunities. My vision therapy practice is an example, right? An incredible opportunity to serve a group of patients who don't have anybody taking care of them. And it also tends to be a big generator of revenue. Myopia management, a prime example, is just not enough people are doing it. And so we've got to help these people. And then with regards to dry eye, the traditional methods of dry eye management and treatment of lubricating eye drops, or maybe a worm compress if you're progressive, that's just the passive way. It's not really helping people. It tends to be that if you are helping and encouraging and helping your patients at the highest level, you tend to be doing the things that are generating the highest amount of money. It just tends to be the one thing. I do want to say this, and I'm not apologetic for dollars at all in any way, shape, or form, but the great thing about having high revenue producing services is when I have a patient who truly can't pay, I can give them a scholarship and get it taken care of. So we are able to cover all of the different aspects. But when you think about specialty services in our practices, I was just talking to one of my practice lead about this. I might see a VSPI exam and make $100, but I do a specialty contact lens or a LipiFlow or an IPL and make a 1,000 or 2,000 or whatever it is. I have to see 10 patients doing something that anybody can do, at Costco or the private practice down the street. I have to do 10 of those to make what I'm able to do because I'm really good at something, and I'm dedicating myself to being the expert in that. So that's why, we're able to generate that additional revenue, and it's very quick. Yeah. Yeah. Bob, I want to mention one other thing about this specialty care. Mm-hmm. When I was talking with a student about this just this week, is I didn't get into optometry to see 40 patients a day or 50 patients a day. And while certain people can do that very, very efficiently, I want to be able to sit and have a conversation. I mean, heck, I talked about politics with a guy today, right? I want to sit and have a conversation with my patients. And in order to do that, I have to generate more revenue per encounter than I do. And specialty services allow me to practice optometry the way I want to help my patients at a higher level than they have ever been able to receive anywhere else.
No, that's absolutely smart. And I see a lot of optometrists. I talk to optometrists all day long. And one of the most frustrating things and the problem I see in the marketplace is that, optometrists are on this hamster wheel of these $40 exams. It's like, oh my God, I've got my patients are full. My schedule is full, but how come I feel poor? How come I feel that I'm working so hard and at the end of the month, I'm not profitable? At the end of the month, I'm not going on vacation. At the end of the month, I've got staff problems. And so the issue becomes, as a business person, as I am, is like looking at this business as a business and saying, look, what do I have to give up? I have to give up something to move towards the specialty care. And what we see in the world today in the marketplace is everything specializes. Your primary care has become commoditized. And the way to really grow is to specialize and find a niche, because that's really where the growth is. That's where the patients are. It's where you have to service, or serve others, but also where you can demonstrate an expertise. So I find that optometrists who pivot into that direction not only find profit, but fulfillment, freedom, and also meaning. And like you said, is that conversation, being able to have that conversation with a patient and have time for that. So I think that's really important. Let's switch now to the process of dry eyes, Dr. Kading. Talk to us about the patient comes in for a comprehensive eye exam. How do you make the diagnosis of dry eye disease?
Yeah. Well, in 2015, I decided to become a crash test dummy in this very thing and develop the process. We invested $150,000 in figuring out dry eye. We read every single paper that was out there. And so I've made every single mistake that has been out there. And if only there was a service which would help me with this process, it would be so much better that we don't have to do that. So that's obviously what Hoot has been fantastic at. The thing is, in the eye exam, the comprehensive eye exam that is an insurance, particularly a vision care insurance, you can't do hardly anything ocular surface related. What we do is we do some additional screening testings that we charge our patients for. So there's an upcharge that every patient has to do. You don't get a choice as to not or do some screening tests like retinal photos, but different ages. So we're doing something on everybody and testing for everybody on it. And if we do see some ocular surface things, then we will potentially bill both vision and medical insurance in a service opportunity that you can do with insurance. But we don't do anything for real management during those comprehensive exams. Those things have to be done at a different visit because you're not getting paid for it. And you don't have the time, especially if you're a large optical practice. You need to get those patients in the optical to buy the glasses, and then you get them back. So there's a couple of things that is really important in bringing that patient back for an additional visit. I find that, and I'm going to just answer one of your questions before you ask it, is one of the best ways that I do that is you have to grab a hold of the attention again, right? So they're expecting you pull the phoropter away or you pull the slit lamp away. They're expecting you to be like, well, your prescription has changed. Here's your new glasses prescription. Your eyes look really healthy, and yada, yada, yada. So they're already thinking about picking up their phone because humans have like a 3-second attention span. So one of the things that I really have found valuable is to say, in looking at your eyes, there's something that's concerning to me. And so that just grabs the attention and it says, I'm listening in. I need to hear something more. What is it that is concerning? And what is it that's raising his attention? And then I will share with them, it looks as if, and I'll go into a spiel, but usually that's around the lines of, it looks as if your body is not creating tears like they should be. There's several different treatments that we may need to implement here, but I need to do some additional testing, which isn't covered by your insurance for an eye exam. And I'm going to need to bring you back so we can do a more comprehensive workup and figure out what's going on and what we're going to be able to do to solve this. And those are really, really key components. And my friend Gina Wesley, who I know you know, has really taught me one of the other big things. And that is, and we use this again during the ocular surface visit, is just to say, you're probably wondering, what if I don't do this, right? Well, we could go on another year and you could continue on with this ocular surface issue with this little symptoms that you have and so forth. But I'm concerned that it will just continue to get worse. And next year we may not be able to reverse it as easily as we may be able to intervene today. So I think those are some key components in getting the patient back to the ocular surface evaluation is imperative. After having invested in $100,000 LipiFlow and everything back in 2013 when things were way more expensive, I had to find a way to get them back so I could increase my conversions. And I know you know this, is you can't do everything in that short visit. You got to get them back for an assessment, whether it's myopia, dry eye services, vision therapy, glaucoma, all of them. You have to bring that patient back for a further assessment, which goes deeper.
Yeah, and part of the reason is that patients' attention span is, like you said, is 3 seconds. They're like, doc, I just came in to get an eye exam and glasses. Like, why are you telling me about what? I can't even pronounce meibomian gland. And yet I'm hearing, so a lot of doctors make that mistake, Dr. Kading, and you said it exactly right, is that insurance is only paying you for that. You really got to bring them back. But part of it is that patients suspect that you're trying to sell them something when you start talking so deeply into treatment and you've got to do this, you've got to do that. We're like, whoa, 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 whoa. It's like everything you say, in addition to, hey, I'll see you back, it's like they're going back and back and back. So that's one of the most important things we've learned in the best practices is you've got to bring them back. So you've got to have the comprehensive visit and then have the ocular surface evaluation for sure. And I love that you use the ocular surface disease, phrase. So talk to us about that. Is that something you do versus saying the word dry eye disease? Talk to us about that.
Yeah, well, that's a big thing. And there has been an incredible amount of work with regards to the nomenclature of this. We mislabeled this condition years ago as dry eye. And the reality is there's a lot of things that are going on. Again, one of the best papers that you could ever read is written by Dr. Korb, and it says dry eye is the wrong diagnosis for millions. And it really addresses this. And so I oftentimes in my explanation to patients, I don't use the words ocular surface because they don't know what that means, but I'll say that there's a problem with your tear film. And really address that. And because sometimes you say dry eye and their eyes are watering and they're like, my eyes aren't dry. And so we may end up saying at some point in the ocular surface evaluation that we do that they have a dry eye disease, which is a really key component. Those are important words that matter. We'll talk about that in a second. But really hitting on that your body's not creating tears like it should. And that's to get them back, we need to hit that.
Yes.
What does it mean? It means that there could be problems down the road. We need to address this. We need to look further. We're going to get you scheduled. We are going to get you scheduled back. It's not like I want you to, or if you'd like to get scheduled up front, it's right. Jennifer is going to get you scheduled for an ocular surface assessment because I'm concerned that if we don't address this, it could be problematic for you down the road.
I love it. I love it. Concerned is going to get you. It's direct. It's clear. And one of the things that, we've read in all the marketing literature is a great book Don Miller wrote called Story Brand. And one of the biggest things he's an advocate of is people are drawn to clarity and away from confusion. So the more clear we can be in the comprehensive exam, I'm concerned, your body, your eyes are not producing the tears as they should. I'm going to get you in next week as soon as possible to do some more diagnostics, and we're going to get an ocular surface assessment. So that's really important. Second thing, one of the things that what I realized, I worked in pharma for years, right? And so one of the things the pharmaceutical industry is really good at convincing patients that dry eye disease equals drops, 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 drops. And while they can be absolutely helpful for symptoms, for improving symptoms, they really don't address the underlying problem with what we're talking about with patients. And so if we say the word dry eyes, then we're risk getting the programming to the patient that I just go to Walgreens, CVS, get some drops, and I'm done. Why do I have to come back? And so it's really important. So I think that is one of the things we're fighting against. We have to think about that, right? We have to make it more medicalized rather than more consumerized, because these companies will do nothing more than to sell lots and lots of drops. And we know that's not going to solve the problem. So I think that's really important, is to talk about the ocular surface assessment. So what are the other words, Dr. Kading, that you think are powerful and valuable? Now, let's say you bring them back for the ocular surface assessment. Let's talk about that. So what do you do in that?
Yeah.
What do you do there? And what are the kind of words you're using to educate?
Yeah. Well, to add on to what you said, when you say that your body's not creating tears the way that you should, well, then one thing we could do is put drops in the eye, but that doesn't change the body making tears the way it should. We need to fix the body, and that gets us to the potential for prescription medications or diagnostic treatments that need to be incorporated in that. So during our ocular surface disease assessment, we fill out questionnaires, and this is a key component, is many eye doctors are treating patients' symptoms rather than their disease. So once we have analyzed things, and just from my perspective after teaching thousands of students in the optometry schools about dry eye disease, ocular surface disease, more appropriately put, is we don't have clear yes or no's when we come to our diagnostics. And so we might think the patient is not doing well, but we may not know to call it a disease. And Michael Stearns has outlined, he's an immunologist that is in the eye care space, is something that is called a localized autoimmune disease, where the body is attacking itself and it's not making it better. We know that is occurring when we see a change in the tear chemistry, when we see that there is a surface abnormality, the corneal surface or the conjunctival surface, or when we see that there is some sort of disruption to the tear volume. And what those three things could be causing ends up that the patient then has a disease. And that's a key component both for patients as well as for us clinicians, because if we're managing symptoms, we're going to be chasing a never-ending tail, like a dog chasing its tail. There is never an end to that. And so Bob, I bring that up to say that the word disease is a really key component for doctors to say to a patient is, you have a disease where your body is attacking itself. And again, I can reference the journal article where it talks about that, the vicious cycle of dry eye. Those are important words for doctors to know. When you know that somebody has a disease, we know that it will get worse and that it's gonna be chronic. It's gonna be for a very long time. So Bob, I bring that up to say that during our assessment of our patients, we use meibography to show a patient about what's happening to their eye. We show imagery of our patients, and most of that is to show what we're seeing. And that's the key component from an educational standpoint. I was joking with a patient today that when my grandfather told somebody to do something, he was the doctor. They just did it, right? Now we have to show evidence and proof of the things that we're doing in order to move forward. We've all seen an MRI or an X-ray of our body because our doctors have to tell us. It used to be they're just like, your bone's broken and here's a cast, right? Now we see it. So saying to a patient that you have a disease and we must intervene so your body is no longer attacking itself, or we reduce the progression. Those are other keywords, is to reduce progression and to make it so the body is no longer attacking itself. Those are key components that drive a patient to say, oh, I want that. And I'll bring that up in comparison to say, a passive approach is to put a lubricating drop in your eye, and that may coat the surface of your eye for a moment, but it's not doing anything from the inside out. So from a diagnostic perspective, I think key words are, you have a disease, it's chronic and progressive, and our approach is to make your body more functional to enhance and improve this. It takes a bit more of a holistic approach as opposed to just a lubricating outward approach. And that drives patients to be looking for those more advanced treatments.
Got it. That's beautiful. I love that. So we have a question. Let's just take a quick minute to answer a question here, Dr. Kading. So here's the question. How do you schedule an ocular surface evaluation? I see 2 comps an hour and an additional OV at the top of the hour. I have a hard time cramming a dry eye eval before the next comp.
Yeah. Krista, this is a fantastic question. The reality is that unless you increase your efficiency substantially, you're not likely going to be able to have the amount of time that you need to further explain these sort of things. And so what I found back when I was not scheduling appropriately is that I was rushing through, and it tended to be a financial waste for me because I wasn't helping the patient really at the level. So I recommend to doctors who are looking to become more progressive in their treatments is go and look at the vision insurance plans or the medical insurance plans that you're taking and just start whittling away at the ones that are low paying for you. And that may reduce the demand on a comprehensive exam so that you're making more money whenever you do see an exam, but it also opens a spot for you to generate more revenue per encounter. And in optometry, a lot of times what we look at is our revenue per exam or per refraction. That's a revenue marker we look at. And what I would highly encourage you to do is flip the panel and say your revenue per encounter. You may see a patient 10 times, but if you're just doing revenue per refraction, all that is, the denominator is 1 in those cases. But revenue per encounter will start shifting how you start seeing your schedule. And we put it in our schedule. In my schedule, I either see half-hour blocks or 20-minute blocks, depending on the day and the support team that I have. But I don't schedule for anything less than 20 minutes with my time with the patient. I just can't get through everything educating them.
Yeah, no, it's great. Thank you for that. And then one more from Krista here. It says, I find with new patients, it's easy to have them come back for an office visit, but established dry eye patients always expect a dry eye check during the comp each year. Any advice on language to make it clear this visit is just another routine exam?
Yeah, you nailed it. That is so true. It tends to be that once I have done treatments on patients, so let's see, I see a new exam, I bring them back for a comprehensive dry eye assessment. Those patients then come back for their follow-up along with their eye exam. At those encounters, if everything is the way I want it to be, I can complete that. I can say, hey, the treatment that we did last time, it worked. We're great. We'll see you in 6 months for another dry eye eval, because we see every dry eye patient every 6 months. Or I'll say, hey, this isn't looking the way that I want it to be. I need to do a little more testing. Remember that testing we did last time? We need some more of that, and your eye exam is not the place for that. And so we'll bring you back for an evaluation for that. They're not always excited about it, but many times I have to do less on a new patient visit than I do an established patient. I do more on a new patient than established. And so I can do a little bit more on established patients. But if I'm going to be recommending, and I'll go in and I'm like, hey, this patient needs IPL, I'm not going to bring that up during a comprehensive exam unless I've got an excessive amount of time for it.
Yeah, no, that's helpful. Thank you for that. And I think one of the things that's really powerful that you said was that, look, you said it in a nicer way than I'm going to say it, which is that you've got to just drop the low paying plans. I mean, it's just, you cannot survive with, whether it's Davis or Spectaro, these visions, they don't pay anything. And it's like, what's the point? And I know that, optometrists have a great heart and they want to serve everyone. You can, but, who are you going to, you're doing it at the detriment of quality time with quality patients who can then, support the practice, the staff, and all the great work that you're doing with the community. So I think it's really important.
You can continue to take those insurances, but you will never become a full specialty practice because you won't have enough time to do it. So Candy Moeller put a question in here as to what special testing I do. And so just to quick answer that, because it applies here, when a patient's coming back for that additional test, we're going to do a more thorough assessment with lissamine and fluorescein. We also do meibography, and then we have several instruments in our practice. I have a MedMont topographer that has a full dry eye suite to it, and I also have the Keratograph 5 at one of my other offices. So at 2 different offices, I have those 2 things, and we can go through the whole dry eye suite of tests within them. Not everything tells me something, and that's the thing, that not every dry eye test is going to tell you something. It's a multifactorial, so there's so many different things that we have to apply here. We also do osmolarity on everybody and inflammatory. And so that's a lot of testing on a patient. And so I can use all of that testing. And I do charge out of pocket for tests that are not covered by insurance. So if a patient doesn't move forward with treatment, that's one of the other things, is they're less, if if they're not willing to pay for a diagnostic test, they're less likely. They're also not likely to pay for a treatment that we're wanting to do. So it becomes a screening for them to even be like, hey, I'm motivated here, right? So I want them in the office, but I don't want them to come back and just say, no, I don't want any of your treatments. Just like I wouldn't want to see a patient for an OCT or a visual field and have them be like, no, I'm not treating my glaucoma, right?
Yeah, that's helpful. And then I have another question here. So Jennifer asked, I have a hard time discussing the treatment options without confusing patients sometimes. Any point?
Yeah. So now let's get beyond disease. And we're saying you have the disease, we have to get treated. And so another key component here is to say to a patient, once you've described everything, is what questions do you have? Not asking if they have any questions, it's which ones do they have, because they will inevitably say, so what do we do? Right. And if they're inviting the what do we do, then it gives the door for you to say, oh, well, I can help that, right? I have a solution for you. Let me share with you some of the things that I'm going to prescribe for you. So one is we don't make recommendations, we make prescriptions as physicians. And so we're going to prescribe something to them. And I think what we oftentimes do is we try to give a spectrum of treatments to patients because we're less confident in our more expensive ones. So, hey, if a patient needs IPL, prescribe them IPL. If they need LipiFlow, prescribe them LipiFlow, right? Don't say, well, we can do a couple of things, right? If a patient is presbyopic, there's not really a couple of things, right? Well, you can hold your arms further away. That's one option. No, you need reading glasses, right? If the meibomian glands are not flowing, you need a treatment, right? Yeah. And that treatment would be thermal pulsation. And so I will say to them, so what I would prescribe for you is I'd prescribe a treatment. Let's use the example of meibomian glands. Like the glands are not flowing. The studies indicate that there really isn't anything else that we could do. The best treatment for you and what I'm prescribing for you is this LipiFlow, thermal pulsation, whatever the treatment is in your office. And what the studies have shown is that we've been able to get a patient to go from less flow to more flow, which is what I'm targeting for you. That's going to increase the quality of the tear films, which we've already discussed is the problem for you. And that will help flood your eye with more oily tears. And that's the outcome I'm looking for. When you come back, I'm looking for the oily tears to be flowing better. I don't say anything about symptoms. I tell them what I'm looking for, what my assessment is, and this is what I want to do. And then if it's something along the lines of IPL, I'll just explain what it is, what we need to accomplish, what our goals are, what I'm hoping to see afterwards, and then what questions do you have, right? And I the question is going to probably come up either from somebody who's listening is, well, what about price, right? So there are times where I do discuss price with my patients, but the vast majority of the time I don't. I have never asked one of my surgeons, and I've had 5 surgeries, how much my surgery is going to cost, right? I just can't imagine that I would ask them that, right? So I just will share with them, when we get you scheduled, they're going to share with you the pricing options that you have, and they'll get you scheduled and all set up for everything and be able to answer any of those questions about insurance or whatnot. And then I'm moving that over to my coordinator in that position. I would really encourage you to work towards a place where you have somebody specialty trained to be able to discuss higher cost items in your office. Myopia management, having a myopia coordinator, a vision therapy coordinator, having somebody on a dry eye coordinator. And that could be one person. That could be your office manager. If you've got 3 people in your office, have one person be primary and one person be secondary. That also attaches that person, the patient, to the one person. If they have a question, they can come back to that person and they know. That can be helpful if that person comes into the room to discuss those prices as well, rather than doing them at the front desk and getting the patient scheduled. So I know we jumped into a lot of different things.
No, this is right on. That's great. And Jennifer, I'll make a suggestion as well in terms of, how you discuss treatment options. So I just want to share a little bit with what we're learning from the 130 practices that are using Hood. So this is the back end of Hood. This is the dashboard for dry eyes. This is only you see this. Patients don't see this at all. And so one of the things that this piece is about visuals, right? Visual aids and stuff. So one of the things our doctors do is finally, hey, Mr. Jones, as we talked about, this is during the ocular surface evaluation. We talked about all these tests we've done. And, what we're seeing is that, when you probably going to Google this, you're going to see a lot of different, you're going to get confused. There's a lot of different treatments for dry eye disease or meibomian gland dysfunction. And this comes from, by the way, from the NIH, right? And so what we've seen in our clinical practice, and what I'm going to prescribe for you is some artificial tears. I'm going to prescribe some omega fatty acids, omega-3s, to get that thick secretion, start melting that secretion. And I'm going to prescribe what is called an IPL. Now, you're probably asking, what doc is an IPL? And so you're just going to go right into the IPL presentation. It's just 3 quick slides. What is it? So you're going to explain it real quickly. It's painless. Use gentle pulses of light to melt that thick secretion, unclog the gland, what to expect during treatment, and how are you going to feel afterwards. Visual aids have demonstrated to help in capturing and converting more patients than not. And the reason is when I speak to you, you're going to remember 30%. But when I speak and show you, recall goes to 80%. So all of these visuals are available for you to educate the patients in the exam room during either the comprehensive visit. This is more for the comprehensive visit, but you can go into it a little bit more in detail when you want it for ocular surface evaluation. So hopefully that helps. Jennifer would be happy to kind of show you the entire system just to get a sense of it, but hopefully that helps.
So many doctors, and you probably have done this, Bob, and you've heard this from doctors, is they've had a binder or they've maybe had, a couple sheets that a rep gave them and they're like thumbing through the drawer, right? We're all on our computers. This is just the greatest thing to be able to just show the patient. It's all there. It's all been professionally vetted. You're not going to have some misspelled word up there that you didn't type into the PowerPoint correctly when you tried to make it, right? It's just professionally done. And it's great for that 80% retention.
Absolutely. And then one other thing I was just sort of mention is that, we talked about getting the patients to come back, right? How do you get the patients to come back from a comprehensive visit to the ocular surface evaluation? And I think your words are really powerful. One of the things we want to kind of do at Hood that we've been doing and playing with really is education. And so I don't want to kind of give a plug, but I just want to show you what practices are doing is between the comp and the ocular surface evaluation, what's called the auto drip campaign. This campaign goes out automatically to patients, Darth Vader here, who has meibomian gland dysfunction. And these videos go out day 1, day 4, and day 7. So again, answering the questions specifically like what the heck is it? And what are the treatments for it? And what if I do nothing? So it's just automatically sent out between the comp and the ocular surface evaluation. And one of the things that we've learned, and Dr. Kading, you're kind of master at this because you're doing so much testing in the ocular surface evaluation. So one of the things we learned is that it requires 6 to 8 touches to convert a patient. 6 to 8. So those of you who are thinking, hey, I'm amazing, I'm going to nail it in the comp, and I'm going to just talk treatment, and I'm going to convert them. Very little chance of doing that. And so what Dr. Kading is sharing with you is these key words in the comprehensive visit, and then back with the ocular surface, and he's doing the tear breakup, he's doing the inflammatory, he's doing the meibography. So these are all touch, 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 touch. And what we're doing with Hood is between the comp and the ocular surface evaluation, 1 touch, 2 touch, 3 touch. So these are touches, and they're coming from the doctor. They're not, they're automated. So it says the doctor's name on it. Yes, it's 2 videos, but again, it's doctor's face, doctor's voice, doctor's video that goes to the patient. And so these touches are what they're doing is educating. That is the secret to more and more signups. It's really about education. So that's just to kind of give you a sense of that. Now, one other question Dr. Kading came up on here is we fill a lot of outside RXs or have patients looking at our frames in our office. How can we get those patients who are not established patients to sign up for treatments no one near us has an RF or an IPL.
Yeah. Well, I think there's two things there. Number one is everybody in your office should be a huge ambassador for the amazing things that you do that are different than everybody else. So whether it's myopia management, and everybody understands that we're not treating kids so that your prescription doesn't increase. We're treating kids so their eyes don't develop disease down the road, right? When it comes to ocular surface disease and treating patients, we want them to look good, feel good, and we want them to really see good. And many people are coming in for the glasses, so they're the see good, right? But that look good, feel good, and see well is really, really a key component. So having in-office explanations or in-office brochures or the sort of things that are hung on the wall, or, window panes or those sort of things are great for that. And then when that optician sits down with the patient to sell them that pair of glasses or to make that conversion, just say to them, hey, is your vision blurry all the time? Or having that one question, is your vision blurry all the time, or is it just once in a while? And then the patient could be spurred towards, answering, oh, yeah, I have to blink a couple of times, but then I see really well. And boom, that sounds a little bit like you may have some issues with the tear film in your eyes. Is that something that you've ever looked into? And then the optician then just made that conversion and can start talking to the patient and say, that's one of the things our doctor here specializes in, and we've got this really cool treatment that helps you see well, see good, feel good, and look good, and then drives those types of treatments. But those conversions can then happen, especially with those patients who have symptoms that they don't know anybody can do anything about.
Right. Absolutely. And one of the things I always had to look at is absolutely, you're 100% right. So, one of the most important things that, my spouse, who's an optometrist, Dr. Shefali, talks about is it's really the emotion that is from you, Dr. Kading, to the patient that makes them convert and to sign up for treatment, right? The emotion and the intelligence and the way you speak and the way you present. Now, the question is, we have these champions, but they're not champions until we train them. This is our staff. So having timely staff meetings and really, really making a commitment to educate and train your staff about dry eye disease is critical. Because even if in that case, the optician did that, nice job in converting, well, we have a lot of times patients, as they're walking down the hall, will ask the staff, hey, what is this thing? Is IPL, should I get it? Right? They're going to ask that because they're like, maybe there's an inside information I can get out of the staff. And the staff's response should be, absolutely, you're making the right decision. Dr. Kading is really good at this. He's got you. You're in good hands.
Yeah.
In good hands, Mr. Jones.
Yeah.
Don't worry. We see this all day long. And so having that emotional connection with the staff and transferring that passion, it comes through with the staff meetings. You can't do it just like, hey, by the way, I want you to talk about a dry eye disease. No. You got to train them properly.
Yeah. Bob, I want to bring up another thing is having well-trained team members is a big key, but having them have the right resources is another key component. That patient who's in and that optician hears something, then it's the sort of thing is like, hey, can I send you a text message with a video that kind of explains a little bit about dry eye and what we do in our office? I can send you 3 videos over the next couple of days that just shares a little bit of information about that, sending them home with some information or helping them understand, even if you're not doing it with that other eye doctor, we just want you to have the education about what's available. And having your team be involved in that is so helpful. On the same side of things with myopia management, Bob, is that we're seeing these patients for eye exams, and then we can send that parent and that patient a couple videos before the consultation, and they had 30 questions that they forgot to bring in, and we answered them beforehand with the video, right? And those little videos that Hoot has is so helpful to really help those conversions because it reduces the amount of time that the patients are having to ask questions in the office. Key component.
And then, so let's talk now about IPL, LipiFlow. Let's talk about these treatments that are gold standard, FDA approved. Again, hint, 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 keywords that you can use, FDA approved gold standards. How do you talk about an IPL? Is it you, and then, are you kind of thinking, well, this patient's probably thinking drops are enough, or you don't even think about that. You just think about like their glands and their tears and how this is going to help their tears. Is that the way you're thinking about when you're presenting the, in terms of the words you use for an IPL? Well,
yeah. Well, first of all, I think that it's all part of the story. So the story is your body's not making the tears that it needs to be making. And so this is an FDA-approved treatment. It's called intense pulse light. And we've done, in the studies, they've taken samples of patients' tears before treatment, done the treatment, taken samples of patients' tears afterwards, and we see that the tears are better. So that means that without even putting anything in the eye, we're doing a treatment that's making the body create better tears. So this is a treatment, and it has a side effect that it may make your skin a little bit better too, but I'm sure, you can get by with that side effect, right? So there's always that little joke about the aesthetic benefit with IPL. Yeah. The converting of the patient to an aesthetic treatment, if they have dry eye, I do not recommend doing during the dry eye evaluation. I think that is an upgrade that you do either at the treatment or your esthetician or whoever's doing the IPL can do later. And so I want to bring that up. If you're using IPL in your practice for dry eye, use it for what the FDA indication is, and that's the treatment of dry eye disease in combination with meibomian gland dysfunction. So share with them what it is that you're attempting to do, and it fits in with that story. Got bad tears, studies indicate.
Yes.
So this is the reason why I'm prescribing this treatment to you.
All right. And then what about an RF? Is the same answer as a question that somebody raises. How do you talk about RF?
Yeah. So, radio frequency has been shown. Go read the studies. That's the big thing I always say, and is create the story for how you want to talk about it. And so in the story regarding radio frequency, we've been able to show that there's been an increase in the quality of the oil secretions. So with this treatment, we are able to alter the tear film without having to put anything in the body. The body is now getting a treatment and it's functioning better on its own. We talk about meibomian gland dysfunction. And so I want to talk about the old dysfunction, and now we have function. Yeah. So now the body's creating better tears on its own.
Got it. And then, so one of the things I want to share with you all, thank you for that, Dr. Kading, is, so this is part of the hood and the back end of hood. And so one of the ways we help you talk about different treatments is a very simple button, toggle. So when you want to educate a patient about LipiFlow, IPL, RF, any of these, if you have any of these in mode, Zest, for example, RF or an IPL, all you have to do is to go from here. That's it, done. Now, what does that do? Well, what that does is it sends one text message and one email at the same time, and it addresses it to Darth Vader, the patient, as we talked about. I'm prescribing IPL. Look at that. It's saying I'm prescribing. It doesn't say I'm recommending. It says I'm prescribing, okay? And then it's going to have these two videos. What is it and what to expect of a treatment? So when the patient clicks on it, again, it's a text message, and it's going to walk them through showing the
associated with dry eye.
So again, it's showing them what the IPL is, what to expect during treatment, and how it works. So what we're doing here is reinforcing what you're saying in the exam room, either the ocular surface evaluation, because I think that's where you really want to get into it. And then at the end of that, when they get the treatment, guess what happens? After they get the treatment, right? After they get the IPL, you'll also have a quick button. And this is something one of our, doctors recommended, is like, hey, listen, what if we had a post IPL video, right? Like, what happens? So all you have to do is to click that, and then the patient gets one video. Hey, what to expect after your treatment? Stay out of the sun, right? I mean, it's these things, when you go to a hospital, I've taken my kids, unfortunately, to the emergency room several times, right, over the years, and you're left with stacks of paper. This is the home stuff that you've got to do. You take this, do this, do this, do this, and don't do that, right? well, wouldn't it be great if there was a video for post-IPL or post-LipiFlow or whatever, or Zest? Well, we have that. That's part of the system. So anyway, that's kind of helpful. That's helpful. Now, we have another great question here, and I think you've answered it, Dr. Kading. And the question is, what does he say about the poo-pooing LipiFlow? Does the LipiFlow treatment for dry eyes work?
Yeah.
That's the question.
So I think this is a clinical question, but I'll also put in here what I say to patients. And so I'm one of the OGs on LipiFlow. I date back to 2013, and I spent $100,000 on my LipiFlow machine. And guess what? I'd do it again in a second. When I brought in IPL, I thought my LipiFlow treatments were going to go down, right? And they didn't. We actually do more LipiFlows today with IPL than we did before we had IPL. And I, from a clinical perspective, I think LipiFlow is still our go-to first line of defense for 90% of meibomian gland dysfunction. So how I describe LipiFlow to our patients is I say the oil-secreting glands that are making the oily layer of your tears, they're clogged. It's like a metal pipe with a big thunk of wax in it. Is we need to find a way to get those glands to go from less flow to more flow. And the studies indicate with LipiFlow, with IPL and radiofrequency, that LipiFlow still is the superior treatment to get all those through. So I'll say the studies indicate that this is the best way that we can get your glands to go from less flow to more flow. So I'm prescribing this treatment because I want your body doing the best that it can to increase the number of oil-secreting glands into your body. So this is a treatment that we do, and then I'll go into explaining how it works. Many of my patients have never needed another treatment, but some of my patients do have to have another treatment every 6 to 12 to 18 months, and we just see how you're doing after the treatment, and then we make those recommendations. I saw that, and I mentioned that because there was a question of how often you're going to need those treatments, and that is a question patients ask. Does this mean I'll never need it again? And I do have to say to them, well, because you do have the disease, we may have to monitor and do some additional treatments as time goes on, and that'll somewhat be dependent on how your eyes are functioning in the future. But we do know that the best way today we can get you going from less flow to more flow is with LipiFlow.
Wonderful. Thank you for that. It's fantastic. Thank you for that answer. And I appreciate that. I think that's reinforced by a lot of things we see. So here's another a question here. Patients are sold in the exam room. Then they find out the cost. Example, $1,000. And then they balk and never sign up.
Yeah. So this is incredible, Bob. And this is the same answer I give with myopia management is patients either leave my office or get treated. And what I mean by that is I'm going to bug them, just like I would a glaucoma patient who is not getting treated. And I will recall you every 3 to 6 months to come back for us to do an assessment on you and see how you're doing. Yep, your bodies are creating worse tears than they were last time we saw you. And so what additional questions have you come up with regards to this treatment? My concern is that you're going to continue to get worse and the symptoms are going to really start ramping up on you. What additional questions do you have? So they can say no as long as they want, but my job is to educate and to teach them and move them forward.
Yeah, and I think what we've seen with all the hundreds of practices we work with now is that we ask the doctor, okay, what'd you do to educate them? Well, I give them a brochure and I talk to them about the comprehensive exam, and then that's it. Or if I talk to them about the in the ocular surface evaluation. But one of the core things we learned is there wasn't a lot of education. It wasn't a meaningful conversation, meaning it was like, hey, you've got dry eye disease. I'm going to put you on IPL, and here's the cost, it's $1,000, right? I know I'm not saying that whoever asked that question, I'm not saying that you're doing that, but often we haven't demonstrated enough value. If we're getting a price objection, so this is a classic case, right? You're getting a price objection. It's either we haven't demonstrated enough value and we haven't educated them enough, or we're not spending enough time with them and touching them in a way that is meaningful to expressing the problem, right? That's the key. Most of the time, that's the case. Because when we see patients out there, they'll spend $1,000 on something else. they'll spend $2,000 on something else. So it's never really an affordability issue. It could be, certainly could be, but it's rarely about that.
It's rarely about the cost. That's for sure.
It's about the value. It's more about demonstrating value. So here's another question here from Kent Yunt. So are you finding IPL acting more as an anti-inflammatory treatment to save MG versus increased mybone flow?
Yeah. So this is a hotly debated conversation around what is the purpose of intense pulse light. So intense pulse light for meibomian gland secretions you also require to do manual expression. And I would highly encourage you to finish your IPL and manual express right away, because meibomian glands cool down within 1 minute of the heat not being there. That may be one of the benefits of radiofrequency, is it may last a little bit longer. I don't know that that's been studied, but that may be one of the benefits. And so if your manual expression is because of the heat from the IPL, that can cool down relatively quickly, but get in there and express right away. I find that doing thermal pulsation with LipiFlow is the most effective way. And there is finally a study that came out in, I think, 2021 or 2022, and I can send anybody the reference if you email me, where they compared how effective the expressions were with manual expression after IPL. And they looked at it in meibomian glands yielding liquid secretions. Then we can compare it to a LipiFlow study. So I could compare two studies side by side. And in those studies that I've evaluated, I show that LipiFlow is a superior meibomian gland expression treatment. But if I want to reduce inflammation, IPL is going to do a better job. And if I want to get the glands that are already open to be catapulted, IPL is the right way to go. So glands are clogged, some sort of thermal pulsation, or IPL with manual expression. If there's inflammation or you're trying to get glands to flow better, then IPL is the way to go via photobiomodulation, which is also something we get with low-level light treatment.
Excellent. Thank you for that. Dr. Kading, so let's just kind of wrap next couple of minutes, just one kind of big question, let's wrap up. How do you get more confident? I mean, you're clearly confident. And I suspect in presenting dry eye disease to patients and getting them to sign up for specialty care for their meibomian glands, okay?
Yeah.
Become more confident. Is it experience? Is it, I mean, you have a great knowledge, a grasp of the clinicals. Like, what does it take to become as confident as Dr. David Kading?
Yeah. Well, I think a couple of things, Bob, is that when you study for an exam and you study and you study and you study and then you present on it, you become more confident. So go out and find the 1 or 2 or 3 studies that can be super pivotal for you to be able to lean on, especially when you're early in these treatments, because you don't have the clinical experience to say, this is what I've found. So lean into the studies and say, the research shows, and if the patient's like, what research? Be like, here's the paper, right? So the research shows that we're going to take your tears from being less quality to better quality. And this is why I'm prescribing this treatment to you. And you're raising your confidence level because you're leaning into some research that you know and that you trust. And then you need to have something that you can give to the patient to further your confidence. And that is that take-home information that the patient can walk away with and can come back with additional questions. And that really will raise your conversion rate way up, right? It doesn't take a whole lot to raise your conversion rate way up. It's the couple of words that you use and then those resources that you provide patients before they come back.
Beautiful. No, thank you for that. So I just want to share a couple. We've been taking notes, Dr. Kading. You'll be happy to know.
Oh, no.
Notes. Yes, we've been taking notes, and we want to share kind of a recap for everyone. So you're kind of clear. You're clear on the best practices and things like that we talked about. So some of the do's that we heard today: do the meibography, objectively diagnose a dry eye disease, lengthen the runway of education, 7 to 8 touches to convert. Don't try to convert in one visit. Reach out more often. The more value you provide, the more likely the patient sign up. As Dr. Kading said, the more we educate them. versus just saying, hey, let's just try to get them, overwhelming them and saying, we're talking about everything in one visit. And no symptoms does not mean no MGD. Really, we need to think about that very carefully. And some of the words we talked about today, meibomian gland dysfunction, ocular surface evaluation, assessment, Dr. Kading you mentioned, and prescribe. Dr. Kading said it very well. Prescribe instead of recommend. Use the term inflammation as well. And then the confidence. How can you become more confident? I think one of the things we've learned also, in addition to studies, is a process. And one of the things we've done at Hoot is we've created what we call the Hoot method. It's really taking the best practices, and it changes every 3 months. We learn from practices all the time, and it requires 3 things: education, automation, and training. And really, it's understanding of those 3 key things can lead to greater confidence. So Shefali and I started a podcast called the Specialty Doctors Marketing Podcast. You can check it out. We just talk marketing, and we don't just talk optometry. We've got a periodontist coming on the show. We've got a plastic surgeon. So you're going to get a chance to learn all about that, and then just check us out, and book a demo and check us out. And I do want to share one additional thing, if I could, Dr. Kading, just on your studies piece. I think having clinical proof is super, super powerful. And one way we do that with Hoot, just to give you a sense of this, I mean, these are, videos that we educate with Hoot Academy for doctors, but we have studies in here. So if you go to studies, we did it for you. These are the top 100 dry eye studies in the last year, 100 of them. And we uploaded it. All you have to do is click it, and you can get a sense of it. You can read it, and you can kind of go from there. But really, the point of all of this is we want to help you capture and convert those dry eye patients in your practice, and utilizing the words that we talked about, Dr. Kading talked about, the process, the whole system, and also understanding the clinical piece of it to make you more confident. So with that, any other last minute questions as we wrap up here? Last few seconds, Dr. Kading, do you want to say any kind of wrap up or recap you want to share?
Yeah, I think the real concern about some of this stuff is that it costs patients a lot of money. And the reality is that's because it works and because it is so important. And we are keeping patients from the best treatments that are available for their chronic conditions because we're not taking the time to implement a process like this. And we may not be comfortable doing saying something that costs a lot of money. So any of the resources and tools like this webinar, these resources that Hoot has, anything that we can do along those lines is not just helping us in our practice with more money, but it's helping patients get what they truly do need because they keep getting worse and worse and worse. And so we've got to find ways to be more effective. And so thank you for what you do in helping us to be more effective with our patients. And, you're not asking me to say this, but I think it would be a great idea at least to learn a little bit more with a demo. Hoot, I know you do that all the time, so those demos are really helpful. So I'd recommend considering that to help build your confidence.
Wonderful. Dr. Kading, thank you so much for your time. Everyone, thank you very much for joining. And I really appreciate you, Dr. Kading. You're a leader in the community. And please continue doing that podcast. I think it's super powerful and leading with a scientific voice. I think that's really, really important. So thank you very much, Dr. Kading. It's been a pleasure having you on the show, on the webinar. And I thank you, everyone else. If you have any questions, just give us a call. Call me, Bob at gethoot.com, or Hannah, book a demo or send her an email, and we'd be happy to talk to you and share all this information. Dr. Kading, thank you so much. Bye, everybody. Have a great rest of the day.
Thank you.
Thank you. Bye now.